This is David Anderson, Member of Parliament. I'm excited today to be able to speak to Dr. Ramona Coelho. She has joined us to speak about C418 and the issues of assisted suicide and the role of physicians in that. As everyone is aware, C14 was passed by this government, which established assisted suicide as an activity in Canada that's supported by the government. And basically within that, there was a provision that declared that no one could be forced to participate in assisted suicide or euthanasia against their conscience. However, there was no provision, there were no framework around that statement. So I brought forward Bill C418, which does set up a framework around the notion of intimidation or threatening to coercing an employee. And basically what it says is that it's an identifiable penalty with a specific penalty for any person to threaten, coerce, or intimidate a person into performing assisted suicide or euthanasia against their will, and also makes it a penalty for anyone to affect anyone's employment status because of the fact that they do not want to participate in this activity. And in the bill, the notion of person, from our perspective, was meant to cover any person, any institution, employers, or actually the governing regulatory bodies. So I'm very happy to be able to have Dr. Coelho with us this morning. She's been a strong voice on this issue. I want to thank you for being with us. And I just want to begin, I guess, by talking about the role of physicians. For centuries, doctors have made a commitment to the Hippocratic Oath. I'm just wondering if you can talk a little bit about that, about the commitment that you make and what that means, and then we'll go into a few more specifics about C418 and the impact of assisted suicide and euthanasia on your practice.
Yes, Mr. Anderson. The Hippocratic Oath, which is the foundation of Western medicine, is eons old oath that we take that is a life-affirming oath. In fact, if you actually look it up, it doesn't just say do not harm. The original oath said, I will not prescribe a poison to kill. And that's because the oath is one about a protection of your patient's life and preserving their health and their quality of life. And I think assisted suicide, euthanasia has posed a real problem for many physicians who've gone into medicine and have taken that oath, taken it to heart, and feel that assisted suicide and euthanasia doesn't fit in with the whole basis of what we're trying to do, the foundations, which is our oath. And so many of us feel that either we have to compromise ourselves or we have to change what we're doing, because our Hippocratic Oath, we meant it, we stand by it, and it's not compatible for us with assisted suicide and euthanasia.
Things are not always as they seem on the surface, and I'm just wondering if you've run into examples or illustrations of patients where they may have at one point felt that they wanted to participate in this, and then you came to understand that would have been a choice that they probably wouldn't have selected if they'd had full awareness of what they were doing and of their situation.
Yes, I'm from Montreal originally. I was born there. We moved to Ontario maybe 6 years ago. And in Montreal, I took care of half-time people who were shut in. Like, I did home care of people with either genetic diseases or end-stage organ failure and severe mental health issues. So I would say that it's not uncommon for me to, as a physician, receive patients' death wishes and then try to help them. And many times when we work with our patients who have death wishes, it's about something else. Like, it's about symptoms. They have terrible nausea and vomiting. It can be about pain control. That's not like we're failing the patient by not giving them proper pain control, and we need to be creative and look for new solutions for them. Sometimes it's about existential crises, about they've lost function, and so they feel like they're no longer valuable because they ascribed their value to that function. And it's about journeying with them and learning, the patient learning to accept themselves. And often they go on to have a great life where they've adjusted to their change in function. Many stories of death wishes that I have, I'll share one with you, arise from family abuse. And I had a patient who was coming to me in my office here in London with her lovely daughter. and she started to lose weight quite rapidly, and we noticed that on her blood tests, all of her nutritional values were dropping. So I consulted geriatrics, I initiated a cancer workup, she's having death wishes. And it was the daughter that discovered some months later. So you can imagine me, the geriatrician, we're all doing this test, we're seeing her with her daughter. But it was her daughter who discovered some months later that she was being abused by her son. So this lovely daughter, her brother, had moved in with this patient to take care of this patient, but was not feeding her and was stealing her money. But she didn't tell us. And I think for us, for a lot of physicians who are not comfortable with medical aid in dying with assisted suicide and euthanasia, it's because of stories just like this, that sometimes a death wish is driven by something that we can't see, which is actually an abuse or neglect, and we can't participate with that. That would just be bad patient care as far as we're concerned, and therefore we draw the line at being able to do those things. I think a lot of doctors, in terms of other experiences that I know that patients, in terms of their death wishes, are struggling with, and is very valid and is a problem, is a lack of palliative care in Canada. Currently, only 15 to 30% of Canadians are dying with palliative care. Palliative care is the expertise a doctor needs to accompany patient at the end of life. So like I was saying, nausea, vomiting, pain, dealing with existential stuff, working on finding meaning in life every day. So I think also a lot of doctors feel that if patients are not being offered palliative care, but are being offered medical aid in dying as their only option, because they're not getting that care that they need, well, that's not really an option. That's not real choice. It's a kind of forcing a patient's hand to choose medical aid in dying, which really is a failure of our healthcare system.
Just wondering if you could talk a little bit about the role of personal beliefs is in your role as a physician, how you see conscience plays a role in your daily function as a physician, and how then you see the role of conscience protections being important in the area of assisted suicide and euthanasia.
Conscience is really the basis of my professional expertise as a physician. Everything I do in my day, every patient I see, I'm always asking myself, what is the best thing for this patient? What are the good things I can offer this patient for their health? And then me and my patient will sit down together and we'll try to figure out, through shared decision making, what path the patient wants to choose with the good advice that I give them. So a good physician uses their conscience all the time. And I would say, like, for example, maybe it's easier with an example. If a patient comes to me and she wants water pills because she has a weight, like a mental health issue in terms of seeing herself as overweight, and she wants to lose water to lose weight, I have to use my conscience there, right? And say, no, I don't think that's good for you, and can we talk about your mental health? Or when I have a patient that I love very much but is not doing very well, and I have to tell them I am contacting the Ministry of Transport to suspend your driver's license because I feel that you're putting yourself at risk, but also the population. Those are times that require courage and integrity to push ourselves through and do what we think is right for our patient. And I think that it's not very hard to see that if you try to tell people, check your conscience at the door, you just need to do this in terms of assisted suicide and euthanasia, I think that's dangerous for our patients. Our patients do better when the doctor is all in thinking about their good. Can you imagine a doctor who checks their conscience at the door and they're forced to do medical aid in dying, or in general, that will lead to demoralization or a lack of using our conscience, okay? And what can happen is that, that doctor who no longer is bringing it all in to each patient encounter is going to feel less motivated also to disclose errors, or to not receive kickbacks from a pharmacy, or to go that extra mile because we feel we're compromised or it's not part of our job description anymore. But conscience is really central to our job description. And I'd like to share just one example of one day. It was my daughter's birthday, and I was done my clinic. I had my back to the door, and I heard the door open and close, and my secretary said, "Oh, do you have an appointment with Dr. Coelho?" And the gentleman said, "No, I'm here for the walk-in." And my secretary said, "Oh, Dr. Coelho is a closed family practice, and by the way, your health card is expired." Now, there's no rule or regulation that I had to see that man. By following any sense of rules, I was entitled to leave and go on my merry way. But I decided to turn around and look at him in the face, because I sensed that maybe he was struggling with his breathing as he was talking. And I quickly stabilized him. He was transferred to the hospital. He ended up being in the ICU for a month for his breathing issue. And now he's my patient, so he's alive and well. But it's my conscience that pushed me to go the extra mile. And I think patient care will suffer if doctors are not allowed to live with integrity and follow their conscience.
I'm just wondering if you have personally encountered any threats towards your freedom of conscience with regards to assisted suicide and the changes that have taken place in the last couple of years. And maybe you can talk a little bit about what does that pressure look like for medical personnel, perhaps not just physicians, but also nurses and administrators as well. And do you find people are in situations where they're beginning to feel that their jobs are threatened?
I'd like to start by answering that question in a hopeful sense, in that our CPSO registrar has recently changed. And our new College of Physicians and Surgeons of Ontario registrar has announced to us that the CPSO is going to change the way that they do things. So in general, I'm hopeful that there will be a change. But currently, as it stands in Ontario, doctors are being forced to participate in medical aid in dying, so that's euthanasia and assisted suicide, by means of a referral. And a referral is a medical act. It's creating a direct pathway for a patient. So it would be before that if a patient came to my office and said they wanted something that I thought was not good for them, I could kindly, without causing moral distress, gently tell them that I don't offer that service for them, but that they could seek other healthcare providers for their opinion. And I might direct them to a hospital or to telehealth or somewhere else where they could get more information. But what our college is saying is that I need to help that patient set up an appointment with the next doctor who's going to go through with that assessment and medical aid in dying. And I think we can think of that in terms of if someone comes to me and I know that they've failed their urine and it has cocaine in it and no narcotics, or I know that they have a narcotic abuse issue, and they come to me, they're like a young person, and they say, "Hey, I would like some narcotics." And I say to them, "Oh, no, I don't think that's good for you, but I know that Dr. Mike down the road will do that for you, and I'll set that up." Clearly, I'm participating in helping that patient get that service. So a referral, most ethicists of all major world religions, even secular humanists, agree that that's participation. And that's where the college stands right now in Ontario. Furthermore, regarding participation and what that looks like in terms of pressures on me, I'm feeling the pressure. Our colleges and other sources have been saying that we should retrain that doctors like me who can't offer medical aid in dying in a family medicine practice should go into things like sports medicine or pathology. Unfortunately, that's a lot of us. Like palliative care does not, in general, palliative care, the society does not believe that medical aid in dying is coherent with their beliefs about meaning of life and trying to make people help people enjoy their life. And so you have people like me who are being pressured to leave family medicine. I know palliative care doctors in Ontario who have stopped practicing. I know nurses in institutions who are feeling bullied, and because of course when our medical college did this, the nurses followed, and as far as I understand, a lot of hospital policy all expect participation now to some degree. And so some nurses have decided to shift their focus or retire early. I know physicians who've left Ontario and moved out of province. The pressure is there, and we are looking for relief.
You've talked about referrals being a pathway, but do you have any suggestions about how the system might be set up so it would allow those who object on grounds of conscience to not participate, but yet to continue to be able to work within the system?
Yes, I think that, we have a precedent, fortunately or unfortunately, in Belgium, in the Netherlands, in Oregon, in Washington, where they don't compromise people's conscience, and conscience objectors have not been picked out as an obstruction to patient access. So it wouldn't be very difficult to look at their models, and we don't even have to look that far. I mean, even in Canada, despite certain provinces struggling with their regulatory bodies, Alberta has done a great job of creating a system that allows patient access without physician participation. And so what that looks like is the patient would come to my office as they would have before, and I would say, you know what, I care about you. You can come back and see me for anything. We can talk about this further. But if you want to have more information about this, which is your legal right, you could contact telehealth. And the doctor would give the phone number maybe of telehealth or a hospital to the patient. And the patient from that point would have a point of contact of resources and information to go forward with that request. As well, the physician, if they received a consent from the patient, would transfer the information from the chart to the person who was doing an assessment so that it could be done in a timely manner. So without obstructing, there are ways to do this where the physician is able to live by their conscience and the patient is allowed access.
Various provinces have taken very different positions on it, and I'd say Ontario is probably one of the more difficult places for physicians with conscience issues to be able to continue to practice. 418, I mentioned a little bit earlier, it's my private member's bill. Basically, it has two provisions to it. I mentioned that a bit earlier as well, but makes it an offense, an identifiable offense to intimidate or coerce anyone into participating in assisted suicide or to impact their employment status. I'm just wondering if you think that this bill is necessary. Is there more protection required than we're providing in this bill? Do you have any suggestions for us or encouragement as we go ahead?
I am very grateful for the introduction of this bill. As I've just told you, even in Ontario and some other provinces, there are some issues with our regulatory bodies, and I'm hopeful that it can be sorted out. But, a regulatory body, every time they change who's in charge, things can change for us. And so it would be a relief if there was some clarification on, like, as we said, the original C14 had said people were not forced to participate indirectly or directly, but we need this bill, C418, to kind of clarify and make it very clear that, everybody belongs in medicine. Because really what this is about plurality and freedom. Canada is a beautiful country where we're all very different, right? There's and we celebrate that. We celebrate our diversity, our different traditions. Like, how wonderful is that we can live side by side and be different and get along. But sometimes to get along, we need to have some creative systems so that no one is compromised. So in this case, patient and physician are not compromised and continue to function. And your bill is wonderful because there are many, many traditions that do not allow a doctor to hold on to those traditions or beliefs and participate in medical aid and dying. And so to keep Canada diverse, to keep freedom of people to choose their deeply held beliefs, I welcome and I'm very glad for this bill.
I appreciate you giving us so much of your time this morning so generously. I'm wondering if there's anything else that you would like to say as we come to the end of our interview, I guess I found it very ironic. You talked earlier about the Hippocratic Oath has a very specific provision in there that doctors will not administer poison, because at the time that it was developed, that was an issue, and here we are centuries and centuries later thinking that we can do a better job by administering poison than by adhering to the principles of the Hippocratic Oath. But did you have any other comments that you wanted to make before we were done today?
No, I am just very grateful. I think that you understand, Mr. Anderson, the issue very well, and I think it's very courageous of you to bring forward this bill. I hope that people see that this is just a good bill for all Canadians. Like, this is not necessarily anything that has to be partisan by party. Pluralism, diversity, and freedom are something that apply to every Canadian, and so this bill should be that every party, everybody wants it. Thank you.
The one thing that we don't need to do in this country is to discourage doctors from serving in our country. We don't have enough of them as it is, and we appreciate the hard work and the good work that you're doing and that your husband is doing, and other doctors who feel strongly about these issues as well. And I want to thank you for having the courage to come forward. We hear from lots of people. Some of them are willing to speak up publicly. Others want to express their concerns privately. But I thank you for having the courage to speak to us today.